So the next presenter is going to be from the USA, Andrew Wiese from Houston, and he's going to talk to us about understanding the connection between pain in OI and mental health and the impact on sleep and fatigue.
All right, well, good morning, and thank you all for having me here today. It's a privilege to be able to be presenting here in such a beautiful city, such a welcoming group here. So my name is Dr. Andy Wiese. I'm a clinical psychologist and assistant professor at the Baylor College of Medicine. And as was mentioned, I'll be talking about connections between OI, pain, mental health, sleep, and fatigue, and some of the research that our team is conducting. Here are my disclosures. More specifically, I want to hit on 3 key points with today's presentation. So I want to discuss the impact that chronic health conditions have broadly on mental health, sleep, fatigue, and what is currently missing within the OI literature. I also want to talk about 3 ongoing initiatives that we have at Baylor College of Medicine in conjunction with the OIF and the BBDC. And then lastly, talk about some upcoming intervention research that we'll be implementing with some colleagues at the University of Ottawa to help incorporate principles of acceptance into the experience of pain for those dealing with, or those with OI. Okay. So as we know across the health psychology literature, chronic health conditions have wide-reaching impacts on mental health, sleep, and fatigue. We know in oncology, specifically with head and neck cancers, those individuals are disproportionately more likely to endorse symptoms of depression compared to those without cancer diagnoses and compared to individuals with other cancer diagnoses. In the context of type 1 diabetes, we know that anxiety and quality of life can be impacted by the disease. Coronary heart disease, we see associations with depressed mood. Specific to sleep and fatigue, we see relationships with arthritis and how that can impact those 2 domains. And then lastly, cardiovascular disease, we often see sleep problems within those populations as well. And this table on your right, my left, it's from an earlier study, but really highlighting that these chronic health conditions have a large impact on mood, and that symptoms of depression are relatively common amongst these folks. Because we know these associations are well established, we know these mental health impacts are present with chronic conditions. As psychologists, we've developed subspecialties. So there's a specialization within clinical psychology referred to clinical health psychology. And within that, you'll have psychologists specializing in different groups of pathologies. So oncopsychology or psycho-oncology, terms are used interchangeably. We have psychologists who specialize in interventions to help families dealing with an individual who may have a cancer diagnosis or a patient who has recently been diagnosed. We'll see psychologists embedded in these clinics rotating with hematologists or oncologists so that we can minimize time from initial identification of depression to getting specialty psychological care. In bariatric clinics, we see psychologists playing an integral role with facilitating behavior change to help influence weight loss. We'll see them involved in the team prior to lap band surgery or gastric bypass, where they do workups to determine is this a suitable candidate for this type of weight loss intervention. We have psychologists specializing in pain, which is directly relevant to the OI community. We have psychologists in rehabilitation settings, consultation liaison throughout hospitals, and then also in behavioral medicine as well, where they work with primary care physicians. So while we know these associations exist with specific chronic disease or chronic health conditions, we already know there's really little research specific to OI and getting these psychological interventions to this population here. So with that, our team at Baylor College of Medicine, in conjunction with the BBDC and the OIF, we're looking to further understand or further characterize what sort of concerns those with OI and caregivers may have, and eventually develop interventions to help address those concerns. So I'll be highlighting 3 studies that various stages, one which has been completed and we're in the process of analyzing data, and then 2, the second study which we're actively collecting data, and then the third will launch very shortly here. So the first study here, we conducted semi-structured clinical interviews with 4 different groups of individuals: adults diagnosed with OI, children diagnosed with OI, caregivers, so that could be parents, spouses. In one case, we interviewed a grandparent who was very involved in caregiving, and then lastly, healthcare professionals who interface with those with OI. And so we conducted these interviews with them. They're very open-ended. We elicited a whole host of responses, and then we transcribed the interviews. And what our team did then was we looked at salient themes that emerged from these interviews for a qualitative analysis rather than quantitative. And the findings here from a paper that was actually accepted a week ago for publication, which was very exciting. It was led by one of our former research coordinators, Mr. Connor Rourke, who is now at Columbia Medical School. And he identified 4 salient themes in his manuscript here. So the first, he noted that loss of mobility due to fractures poses significant psychosocial burden amongst adults diagnosed with OI. So that 1, 2, 3, where it says negative affect after fracture, more than half of our participants are endorsing symptoms of depression immediately following fracture. We also noted feelings of hopelessness and anger following fracture as well. The second theme Connor uncovered was that different phenotypic characteristics are associated with feelings of isolation. So isolation broadly, and then also romantic isolation was noted by our participants that we interviewed. Connor identified that unpredictability of fracture leads to future anxiety. So this worry that I could have a future fracture or future injury was noted by a large number of our participants. And then anxiety related to social interactions with others. Well, these outcomes that we identified may seem negative. We did also note a whole host of positive outcomes in the individuals we interviewed. So things such as optimism, minimizing the impact that OI may have on life, identifying challenges that have been overcome. Our participants we interviewed told us that these things helped buffer against some of these adverse outcomes such as anxiety, depression, and things to that effect. So what we took from this is that we could use this as a potential jumping point for interventions. If we can develop interventions to foster feelings of optimism, overcoming challenge or resilience, using different cognitive techniques to challenge some of those interpretations of difficult events, we may be able to buffer against anxiety and depression. One of the projects we have, or one of the manuscripts we have in development right now is being led by Ms. Whitney Shepard, who's one of our current research coordinators. She took these same interviews, so 15 adults diagnosed with OI, where we had these very broad, open conversations with them, and she wanted to look specifically at pain and what these individuals were reporting to us. So she identified 3 themes. The first of which was that pain management varies based on type of pain that they're experiencing, perceived risk of pain, and then accessibility to different pain modulating interventions here. So as the table shows, almost all of our participants endorsed acute pain at some point in their experience with OI, and more 1/3 of them experienced chronic pain throughout the lifetime. They engaged in different coping mechanisms such as reactive and preventative measures. And then concerns of medication were also noted among some of the individuals. The other 2 themes that Whitney identified, OI has different cognitive, behavioral, and affective outcomes associated with pain. So activities of daily living, that was an area that seemed to be impacted for a large number of our individuals. Sleep interference, loss of mobility. And then on the affective side, feelings of fear, sadness, things to that effect were also endorsed. Lastly, individual differences. I know we were just talking about weather and temperature and climate and how that can influence pain. So this is very timely because we have data on that. But in terms of contextual factors, about 1/3 of our participants said cold weather actually exacerbates their pain, it worsens it. So there might be something to that earlier conversation we were having, that warm climate, perhaps we should all go to the Maldives and enjoy the warm climate there. There may be something there. The last point that I want to highlight here from Whitney's study, this bottom line here, provider minimizing pain. Just over half of our participants noted experiences where their healthcare providers didn't understand their pain, or they felt as if it was minimized and they were given messages of, well, this is a chronic condition, you should know how to deal with it. As we were analyzing these transcripts and reading it line by line, it was really jarring for us to see these anecdotes, and members of the OI community share this with us. The next study that we have going right now, I'll touch on briefly here. It's a longitudinal study that we're conducting with members of the BBDC, where we are doing we're assessing 3 time points with adults, children, and then parents of children who have an OI diagnosis. And we're collecting self-report measures to see how these co-vary with health events, health interventions that they have, and how they change across time. So this table here is just a snapshot of some of the constructs that we're assessing in these 3 groups: our adults, our children, and our parents. We've mentioned before that adults have historically been underrepresented in this research, so we're very excited to expand this data set and look at how these symptoms or how these domains change across time, and again, how they co-vary with different health events. With our children, these batteries are broken up further, where we have smaller batteries tailored to our itty-bitty kiddos, our 4 to 7-year-olds. Our older teens, they have a more extensive battery. That was some of the feedback we received from the group, that it'd be more appropriate to have more questions with older kids. And the last group that I'm particularly excited about are the parents, where we're not just going to look at parents' perception of child's anxiety or parents' perceptions of child's pain catastrophization, but we want to look at the parents' anxiety, the parents' depression, the parents' sleep patterns, and see if that shows associations with how the child scores on some of these measures. In the anxiety literature, we know anxious parents tend to foster anxious kiddos. So if we're looking at a health population, we're really curious, does a parent's anxiety, is that associated with perhaps a child's elevated pain catastrophization? If it is, it may suggest we need to develop interventions for parents so they can modulate their anxiety, so that child then has a more beneficial response when they're dealing with pain or things to that effect. And the last study that we have going at the moment, or will be starting relatively soon, is an in-depth, very long survey. So for those of you who participated in it, I apologize in advance. It may be a long one that we express our frustrations at the next conference about, so I apologize in advance. But we're looking at certain predictor variables and moderating factors here. So if you look at AIM 3 here, a couple of rows down where it says shared decision making, well, we're borrowing from other health psychology literatures, and we want to know, does shared decision making predict things such as perceived disease burden? And is that moderated by perceived control of OI and things to that effect? So this is going to be a very large survey. I think we're targeting about 300 individuals, and that should be launching relatively soon. So once we establish these associations or these causal relationships that we suspect may exist within the OI, we really need to start developing psychological interventions so that we can help get people the relief that they may need. So we do have an upcoming study that will be launched with Dr. Marie-Eve Robinson from the University of Ottawa. Then my colleague, Dr. Eric Storch, is also heavily involved in this. But it's a mindfulness-based intervention to help influence how individuals experience and interpret pain. So we're going to recruit 60 adolescents and 60 adults. They're going to be randomized into an active intervention and a control placebo condition. After the end of the trial, those that were in the control condition will be put into the active intervention phase so that everyone receives the intervention at some point. We suspect it should cause some benefit. Prior to the study, we're going to have a needs assessment, and we're going to do some pilot feasibility testing to make sure that the individuals with OI believe we're targeting these symptoms correctly. It'll be 8 weeks, as I mentioned. We'll assess outcomes at the end of the study, and then 12 months out, and then at the end of it, we'll be assessing things such as feasibility, compliance, and so forth. So with that, I'd like to thank everybody mentioned here and many, many more, including our participants and everyone here today. And I am happy to field questions for however much time we have available.
Yeah. Thank you very much. That was a very interesting talk. We have time for questions.
Hello. I have one question. Is there a difference between a parent's interpretation of the problems for the child, because one of the parents has OI himself? Is there a difference between the OI parent and the non-OI parent in the interpretation?
Yeah, that's a really good question. So there very well may be. I mean, we don't have the data quite yet from that survey, but that would be an important consideration. Does a parent with a parent with OI with a child with OI have a different interpretation of the child's pain versus a parent without OI with a child with OI? Yes, I suspect that experience would inform it, but again, we just don't have the data quite yet. But thank you.
Hello, my name is Annemette Bredal, and I'm a health psychologist myself, so I'm very excited to find another psychologist, because in this rare community, we are even a rarer community, so we need to work together. At the moment, at our center in Norway, we are also doing an intervention study, and video-based group intervention aimed at people with short stature, not always this time, but we're trying it out. So it'd be super to maybe get inspired by each other. My question for your excellent talk was, did you find any, did people find that there was offers to help them deal not only on the medical side of the pain, but also living as good as life as possible with the OI? Because that's some of the things that we experience in our country, that we have very good medical care that can always be improved, but on the psychological side, it's difficult when it comes to health psychology.
Yes, that's an excellent question, and I appreciate hearing that you are also a psychologist working within a health population. Yeah, I mean, I think that's a never-ending issue or area that we can improve in with chronic health conditions. You know, the disease or the condition may be present. We may have medical interventions to minimize symptoms or the experience of pain, but that doesn't necessarily address quality of life, day-to-day functioning, ability to live life the way that you want to do it and kind of maximize oneself. So I'm particularly excited with these acceptance-based interventions within psychology, where we can look, how do we allow this objective truth to be there, right? The presence of an OI diagnosis, but still maximize one's life and do the things that you want to do to the greatest extent possible.
Yes, and I guess Samantha has a question. And Rebecca?
Yes, just a very quick question. So, from the patient community perspective, did you ask or map whether being a member of an OI organization or a part of a patient group or being involved in peer-to-peer group activities had an impact on the mental health or pain coping strategies?
I don't think, so that first study where we did those open interviews, I don't think we explicitly had any questions about that. But I also suspect many of the participants that volunteered for this study were actively engaged with the OIF or OIFE. Well, not the OIFE, we only recruited from the States. So, but no, we did not have a question specific to that.
There might be a link there.
Yes, there'll be a limitation in our next manuscript we write on these data.
Yes. Samantha?
Thank you. It was just a comment really in response to the question about parents or caregivers' perception versus self-reported, and just to say that we have quite a lot of data from the impact survey whereby we can compare experiences reported by individuals and look at how potentially parents perceive pain or other signs and symptoms or the impact of OI on different people. So hopefully that might be an analysis we could work on.
Certainly.
I was wondering about the survey you mentioned, as usual. Is it only for the US or are you planning global? Which languages do you need help to spread around? And you said also something about shared decision making, but I didn't get that. So.
Yeah, so first question, so where are we going to be administering this survey? It will be in just North America, unfortunately, and only in English. So one of the reasons we're doing that, unfortunately, is that these questionnaires have been validated in English. They haven't necessarily been validated in Dutch language with a Dutch population or in German language with a German population. So we are going to be a little bit constricted in that respect. And then your second question, shared decision making. Yeah, so this is borrowing from other health psychology literatures where we know when patients are actively involved with making decisions about their care, what's going to happen versus not, rather than a physician saying, you need this intervention. We know that it's associated with better mental health outcomes and better perceptions of the healthcare that they were given. So we're basically borrowing from what has existed in other health psychology literatures and using that to inform what we're doing here with an OI population.
Okay, thank you very much.